destination and have best treatment. So what the World Health Organization say, there is a life expectancy gap of around 18 years between the richest and the poorest countries due to unequal access for the healthcare. AI offers the potential to close this gap and increase the efficiency and accessibility. Also, utilizing AI-based digital technologies, we can personalize and give advanced, timely treatments with modern data. So we hear the word saturation. We hear that we have too many orthopods, we have too many anesthetists, too many doctors in our current city or state, wherever we stay. But we are still short of 9 million doctors. We have close to 0.7 doctor per 1,000 population, where other countries on a global average is 1.8 to 2.2. We are also short on nurses. We have 1 to 1.7 nurses, while other countries have 5 nurses per 1,000 of population. So we are still quite short. So the doctor-to-patient ratio in India is 0.7, where the global average is 1.4, and other countries it's 1.7, 1.9. There is still 83% shortage of specialist medical professionals, according to Health Ministry data. In terms of evolution, we all started off with carrier pigeon sending off messages, smoke signals coming through, messages in a bottle, Pony Express telegrams, balloon mail telephones, and we evolved into cell phones and modern AI technology. So the healthcare evolved from informal caregiving and spiritual healing to science-based technology development. So going across with the evolution of healthcare, we all transformed from episodic care to continuous care, where there are remote monitoring and diabetic sensors installed for real-time monitoring, and from subjective judgment to quantified data, where we have digital imaging, digital vital monitoring, and Apple recently formed out a mirror where we can wake up and stand in front of a mirror. We can see all our vitals in a single frame. We also evoluted from one-size-fits-all treatment to precision medicine, which is the crux of current technology, based upon genomics, epigenomics, and targeted therapies. And we also evoluted from hospital-only treatment to hybrid virtual care, where it incorporates telehealth and in-person treatment. So why tele-ICU? The programs concentrate more on clinical resources in remote care centers to bridge the gap between the richest and poorest countries. It provides care in distant area, round-the-clock, 24/7 availability, reduces the financial burden, scalability of the beds increase, helps in early diagnosis, prompt treatment, and improve the level of existing ICU care. So these are the other financial benefits of tele-ICU: reduction in the length of stay, paperless workflow, electronic health records, reduction of overtime, scalability of the beds, and accreditation and easier insurance claims and settling. So we also have the round-the-clock surveillance from a central command stage center, where collaboration and support is available from all subspecialties and super specialties. So AI is based upon 4 main things. One is AI-based telemedicine is based upon 4 main things, to be precise. One is machine learning, where it analyzes the patient data, personalizes the treatment, and gives the plans. The second one is NLP, which is the natural language processing, which is a very nice tool, have a chatbots, and personalize the medical drugs and treatment. The other one is a computer vision, which incorporates convolutional neural network. So that detects the cancerous lesions, diabetic disorders quite early. And there is also deep learning, which detects digital X-rays, MRIs, and interprets very quickly. So this is all where it began. This was more than a decade ago, where Cloud Docs, this is a personalized version of tele-ICU of Ramesh Hospital. So it incorporated 3 main principles, where we input continuous data streams from electronic health records, monitors, and lab systems. Then we process by AI algorithms, and output alerts were given quite quickly to clinicians for early interventions. So we created this network across all the ORCs, outreach centers, keeping the 3 main hubs. The Vijayawada Hospital, 2 hubs. One is the cardiology and neurology, and the Guntur Hospital being the multi-specialty hub. So these are the ORCs that are spread across a couple of districts nearby to us. There's more than 20 ORCs where we collect data, we monitor real-time patients, and we have also expanded to several other hospitals for easy access. So this is a slide which shows the central command station. And once the command station finds any abnormality, the announcement of tele alert goes through quickly. Direct point of care alert goes through a hub, which is visualized, and audio message has been sent quite clearly. So there's a dual assessment at all points, where there's an audio video connection and there's also multi-parameter monitoring. So together, things are analyzed by 24/7 doctoral support. This is how CPR is being monitored in the emergency room. And we also have a sophisticated tele-ambulance where we give continuous alerts and monitoring advices. This is the TeleSmart ambulance where we can see the nurse giving out patient data, and we are giving prompts through the speaker. Couple of examples in the recent time in the perioperative period where we have detects being alerted quite quickly. So there's a 38-year-old female who had an emergency laparotomy for obstructed hernia, developed suddenly shortness of breath and severe tachycardia and ventricular tachyarrhythmia on postoperative day 2. This alert was given in 10 seconds time, the quite quick response time, and she was shocked and she was fine afterwards. Couple more examples. Resection of prostate, day 1, type 2 diabetes, hypertension, COPD, and ischemic heart disease history, develops breathless suddenly and respiratory distress. So he's been alerted quite quickly. And another case which has actually come to a cath lab with acute coronary syndrome, had anterior wall MI, initially stabilized with medical management, then shifted to cath lab, had the procedure, good TIMI flow, and went to HTU where there's an alert, she suddenly got worse. So in terms of perioperative period, how things work. So this is how real-time monitoring happens. Like I said, dual monitoring, where we see an operation theater monitor and there's a person who is constantly monitoring the vitals in the tele-ICU department. So alerts will be given straight to the operating room in case if anything is missed, even though we have a constant anesthesia monitoring over there. So we all started off from 2000 BC, and initially there were days where they used sponges soaked with opium and mandrake plant for surgical pain relief, but now we have evolved slowly into robotic anesthetists where robots can intubate patients. So the augmentation of artificial intelligence in the perioperative period, so it can be divided into 3 things. One is the preoperative AI, where it predicts the preoperative risk, estimates transfusion needs intraoperatively, predicting difficult airway, and pre-op stratification of postoperative complications. The intraoperative AI, which is augmented, helps in making decisions regarding regional anesthesia, intraoperative monitoring, prediction of hypotension, fluid and vasopressor administration, and depth of anesthesia. While the postoperative AI predicts in adverse events, alerting changes of the patient condition, discharge planning, and optimizing pain control. So other modalities of AI used in telemedicine. So we have AI-powered wearables, teleconsultations, medication management, virtual triage, remote monitoring, diagnostic assistance, and rehabilitation. So in terms of AI development in anesthesia, so we have CLADS, which is a closed-loop anesthesia delivery system, where, like Mahesh sir said in the morning, determines the right drug with the right dose at the right time. So it has a constant infusion pumps, which the data is being monitored through a computer-generated-based system, and the vital signs are monitored in a different screen, and the depth of anesthesia is being monitored by the bispectral index. So it helps in ventilation control, hypnosis control, nociception control, neuromuscular control, temperature and metabolic parameter control. So this is the first robotic tracheal intubation done in 2012. So this has a success rate of 91%. A recent study showed the success rate has increased to 98%, but even 2% non-successful intubation, that can lead to mortality. So it has a couple of arms, robotic arm, joystick, and a video laryngoscope and a software control system. The other feasibility of automated total IV intravenous anesthesia drug surgery delivery system for the cardiac surgery has also been tested. This is also a closed loop system like CLADS before. So there's something called cutting edge artificial intelligence model for AI enhanced electrocardiography. So this is used for complete heart block dissection, identification. So the success rate was 84 to 94%. So people were tested based upon their ECGs. They were about 7 to 12 times more likely to develop complete heart block compared to low risk patients. So another AI intervention. So this has a sensor. A sensor is placed and the ECG is connected. So based upon the sensor and the ECGs, AI-driven AF detection in embolic stroke patients can also be used. So this has high success rate in the recent times as well. So we are changing slowly. Most of the radiologists might not like this slide, but in terms of efficiency, the radiologist detected anomalies are 78% accurate, while AI detected anomalies are 92%. So comparison between radiologist and AI detected anomalies, we still have almost 15 to 18% difference. AI related interventions in critical care, we can detect the sepsis early. We use Muse and SOFA score, where the sensitivity is 70 to 75%, but AI solutions give the score of 90%, specificity of 65 to 70%, and AI solutions give the score of 90% again. And the main difference between AI-based and traditional scores-based sepsis detection is in the response time. So based upon traditional scores, we have a rapid response time of 2 to 4 hours, while real-time response and within minutes, you can actually detect sepsis and intervene quite early. So pros and cons of AI in healthcare, is it good or bad? But it also depends upon who created it and for what purpose it has been created. It's always a double-edged sword. It offers immense potential for faster, more accurate diagnosis, personalized treatments, administrative efficiency, and decrease in bias. So the main advantages, we can see there's a breakdown of time savings. Data analysis, we have 15% improvement. Alert generation and critical incident detection, 10% improvement, and decision making, it helps around 5%. So anything out of these three, that's always a plus for the patient to detect the sepsis early and intervene early. In terms of challenges, privacy and security concerns are always prevalent for AI, ethical considerations, data quality, precise algorithm division, automation and job losses, volatility. So overcoming these challenges requires strong collaboration among healthcare providers, technology developers, and regulatory bodies. So the current ICU rounds involve many of the clinicians. You need a critical care consultant. You need sometimes you need anesthetist. You need cardiologist. You need neurologist and a parent consultant, and a physiotherapist and dietitian together to have a multidisciplinary round for a critical care. But in future, you will have a single person sitting in a robot docked and operates with multiple arms, and he will be able to do everything what all these people can do. So I don't like the automation and job losses, but I'm afraid the future will be different. Predictive analytics, clinical decision support systems, natural language processing systems, and real-time alerts are going to play a key role in the future ICU rounds, where, like in the photo, one can sit in the docking station and do everything. Don't have copyright for this photo, so I might be sued later. So the medical futurist envisions that AI is not a replacement for doctors, but it is an essential tool. Like we had stethoscope for the last two decades, I think AI will become the stethoscope for us in the next 2 decades. With the advancement of AI, telemedicine is also set to become increasingly efficient, accessible, and focus on the needs of the patient. So diagnostic accuracy, tailored treatments, and broadening of healthcare is the primary goal of our AI-related telehealth. But on the same way, like it's a double-edged sword, we also need responsible use of AI to uphold patient safety, privacy, and deliver quality, precision-centered patient care. Thank you for that.